Thank you so much. Now we have about 20 minutes, and let's take a few questions from the audience. The first question is directed probably at Peter from Ellen Martin. She's curious about how the panelists see this initiative fits in with the CMS National Quality Strategy and other nationwide efforts to improve health.
I defer to Elizabeth. This is Peter. I'll let Elizabeth start, and then I'll jump in because I think she's probably closer to this.
Sounds good.
How this aligns with the National Quality Strategy, I think that there is a lot of movement towards, CMS is very much aware of the need to align measures, and they are moving upstream, I think, in more impactful measures. We're looking at patient-reported outcomes, measures done with built with clinical data. The problem, honestly, often comes down to the data infrastructure to actually produce those measures. So I don't want to speak for CMS, but I think that this aligns very nicely with where they're trying to go.
And the only thing I would add to that, this is Peter, is the Accountable Communities for Health, or the Accountable Communities for Health in California, which is a forward-looking population health work, and the Accountable Health Communities funded by the Centers for Medicare and Medicaid Innovation are leading in this direction as well, which is the measures that are health care and health measures that kind of bridge what we've been talking about today. So you can see also, in addition to harmonization and alignment, I think the future-oriented work is heading in this direction in many different places.
Thank you. That's a great question. The next question, I think it's directed at Steve and probably for Steve and Sue, and particularly in terms. So this is coming from David Stevens. Could you describe what you've learned about engaging leadership support in using data and also aligning existing initiatives and priorities? Thanks so much.
Well, I think that the learning, of course, aren't new. The first is that it does take leadership, and particularly leadership that's at the community level and that can engage the critical stakeholders within those communities if one's going to have anything more than sort of a dull set of data that just sit out there and don't get used. And to engage them really requires identifying those community leaders who are actively engaged and are passionate about it. We were very fortunate that Cultiva de Salud and Veva were there in Fresno with deep roots in community and passionately interested in change and using data to drive change and wanting data that were a little hard to secure there that really enabled us to do that. And as you heard, we had a similar situation in Monterey where Krista was already engaged in a very meaningful process to engage the community as part of Impact Monterey with many of those stakeholders, but it required her leadership to and real roots and a lot of prior effort to enable them to actually move forward in a very active and productive way, and willingness to see how these could be integrated into their processes and actually help them. So I'm not sure I have any great insights other than it takes work. You need to go out and canvass people, find out what's going on in those communities, find out where the opportunities are, and then identify those leaders who can help you do that. Sue, I don't know if you had anything you wanted to add.
Can you hear me? Okay.
Yep.
Yes.
Yep.
Okay, great. So thank you. So I think just to tag on, I think one of the philosophies that we use is really providing opportunities to broaden people's perspectives. I think we all have kind of our own ways of thinking things. And so when you create a space for dialogue, and it's an open dialogue, and you use tools such as live stories or other tools, I think those that are in leadership, you know, if they're also in the right space, can begin to see like, oh, there's maybe something that's contributing to what's going on. And so I think that's kind of another piece of it that I think is really important. It's the approach.
And this is Chris. I'll just add to that. I think the two sessions we had, what was really great about the way they were facilitated is they were incredibly engaging and different. You weren't just sitting in linear tables. You were, you know, in circles. And working with the illustrator, I thought, was a great way for folks to visually see their ideas and their priorities coming out onto the paper. And so then it was easier to bring them back to the table. And then also, as I was reaching out to engage leadership, I was very intentional about trying to find out what their priorities were, what was important to them, and finding those links with core metrics, which, as you've heard, everyone's trying to measure, and there's various reasons. Maybe it's reporting on grants, or maybe it's for writing for grants, but for many of the community organizations, they do want to measure, and they just don't have the capacity to necessarily do it themselves. But the data needs to be put into the hands of the people for it to be effective.
Thank you. And then we're going to take a last question. I think several panelists can probably answer, and this reflects some of the ongoing work here at the Academy. The question is from Edward Dick. Will there be a reconciliation of vital signs, such as with HEDIS, social determinants, such as the CMS accountable care communities, NACHC's PREPARE, the county health rankings, et cetera? What are the levers or interventions that really will move the needle the most? Dr. McGinnis, do you want to take the first step?
Thank you, sir. I'm happy to take a first cut at that. It's not surprising that with proliferation of measures across the board and the fact that we're early in the stages relatively and actually moving toward the full-scale implementation of a vital signs set of metrics, that there is substantial need for reconciliation among different efforts. Many of these efforts are relatively early in their maturation. For example, the CMS work with accountable health communities and the kinds of measures that might be used in that respect are still relatively developmental. But I'll underscore two things that I think are important in moving forward to try to reach commonality with respect to which measures are used. We, as you implied, Claire, in the National Academy of Medicine are committed to developing what might be termed loosely a version 2.0 of the vital signs metrics, which in effect takes the committee set of 15, works within the framework of the 15, and identifies with greater specificity the composite elements that are necessary for those that require composite expression, drawing from the work that's been undertaken in various quarters, and then working with the various sponsoring agencies and organizations and to see if we can effect a greater consensus and consistency in that respect on a individual organizational basis as sort of a consensus activity. But most importantly, I think ultimately it's the second piece that is important to comment on, and that is that ultimately for vital signs to reach its full potential in both focusing action on measures that matter most and in terms of providing reliable for lack of a better term, research and scientific base that allows reliable comparability across various initiatives, the federal government is going to have to play a stronger role. And there is receptivity to that. We've been working with CMS and with the Public Health Service in the initial stages of conversations. It's not that they need to set the actual measures, but they need to steward the process that will help in the ultimate reconciliation of the measures involved. There is a willingness and I think an interest across the nation to have this resource as a means of improving processes and outcomes, and so this is an area in which we have to take the medium and longer term view, but with the kind of initiative that we see here in the examples that have been given in California and elsewhere, I think that we'll be able to get there. I'd actually like to, if I can, ask Peter for a question that is related in this respect, and that is, given your focus on issues at the community level, as well as policy issues that provide the kind of air cover that's necessary for community-level progress, and obviously Medicaid is in many respects the most important policy issue in that respect. As you look at the important discussions that are underway around Medicaid, what do you see as the strategy that might be most effectively employed for Medicaid, both at the state and at the national level, to take full advantage of the vision that's embedded in vital signs?
Wow, that's an easy question. Thanks, Michael. So I'd say a couple of things. I think my answer to the first question is actually related, which is I think what we've demonstrated the feasibility clearly, which is around community engagement, leadership, shared outcome measures, and not necessarily the whole data infrastructure that Elizabeth was referencing, but the ability that Steve and Sue were talking about, that you can pull data. So those four elements, I actually think, which are vital, have been shown to work, and that they've been shown that good things happen, in the sense that positive change can happen to improve lives. We think the next two, which is related to your question, Michael, which are around how do you tie it to finance, so actually you change the way that you pay for things, and then we think the lagging, not because it's not critical, but just lagging in the sense of the way the world works, is the policy framework to actually support it. And then I would add Elizabeth's point around it's more than being able to collect the data, but it's actually a true data infrastructure that allows that currency to, the data currency to flow freely across sectors at the community and county level, at the system level, and just as a freer flow of information. So I think, to highlight your point, the opportunity for me, as we see it, is to actually inform the Medicaid conversations with the work that's happening in Monterey and Fresno and Santa Cruz and other places in California and throughout the country, as the opportunity, the obligation and the opportunity under Medicaid to actually improve the health of the population. And we've made great strides, but Medicaid is the place where you really do look at health and social services together. You look at vulnerable populations and think about what do we need to do to improve their outcome measures. Many are high cost that actually have opportunities that Elizabeth was mentioning around cost reduction. So to me, if we actually use this work and use vital signs as our keystone to the Medicaid discussion, I think we'll actually be much further ahead, rather than assuming that Medicaid is just a financing mechanism and we narrow our conversation just around how do we pay for a discrete set of healthcare services. If there's any place where this conversation is relevant, to me, it's in the Medicaid population, both because of need and because of the opportunity.
Well, and to pick up on a word that you used in citing Elizabeth, the data infrastructure has to start with vital signs.
So here is the very last question that just came in. I believe this is directed at Viva. The question is from Agnes Musinska. Transportation inequities and lack of community safety are certainly barriers to better health, but how would you quantify optimal budgetary investments in those areas based on direct impact on health outcomes?
That's an amazing question, and I'm not really sure I have a good answer for it. But I think if in the Fresno example, we can see a trend over the last several years of disinvestment in things like animal control, of proportional disinvestment in things around resources to support parks and recreation. And I think if we look at those type of city investments into amenities that promote health, when we then see advocacy that brings greater investments in that area, that certainly that is an achievement. I think when we get those budgetary investments back to and beyond the previous highest levels of investment, then I think we're looking good. So I think that, yeah, some of this simultaneous tracking is going to be necessary, where we're looking at sort of the financial investments and the health outcomes. But I'm not sure if that's been done before and if there are best practices around that.
Sounds like this is going to be an ongoing conversation. For the sake of time, I want to invite you to join the conversation and engage with us as we continue to expand our work. So do reach out and tell us about communities or organizations that are applying vital signs framework or planning to do so. We know that there is an ongoing effort in Tennessee, and several accountable health community models across the country are considering vital signs for their measurement and evaluation activities. So please do reach out. How do we map and align driver measures or process measures and levers with the core metrics, which was raised earlier in the Q&A? So these are essential to drive system-wide change. So any strategies and ideas, please do let us know. What kind of data infrastructure and composite measures have been most useful, and to what organizations we should continue to engage? Finally, how can we build a national partnership and learn from each other to have shared resources so that organizations coming on board would not be starting from scratch? So with that, on behalf of the Academy, I want to thank the speakers for your time and thank everyone on this call for your commitment to measuring what matters. Today's recording and the slides will both be posted on our website within the next week or so. And don't forget, you can download a free copy of our report and other related resources from our website. You're also welcome to check out our upcoming event on high-needs patients on July 6th, also chaired by Peter Long. With that, I'd like to thank you all again for participating. Have a good day.